Hello, and thank you for your interest in my presentation. My name is Estefania Rubio. I am a physician by training and a maternal and child health epidemiologist. I am the data manager at the Florida Perinatal Quality Collaborative, and today I want to share with you how we improve the timeliness, accessibility, and granularity of an automated hospital perinatal quality indicator dashboard in Florida. But first, let me tell you a little bit about our organization and why we decided to work on this project. The Florida Perinatal Quality Collaborative is a statewide partnership dedicated to the advancement of perinatal health through quality improvement. We are a true partnership. The collaborative includes perinatal-related organizations, health professionals, advocates, policymakers, hospitals, and payers that aim to improve maternal and infant health outcomes. The collaborative is voluntary, it's data-driven, population-based, evidence-based, equity-centered, and value-added. As you can see, one of our values is that we are data-driven. Through data, we identify the most serious maternal and infant health issues in the state, and then we lead 2 maternal and 1 infant statewide quality improvement initiative. Early on, we identified the need to increase awareness and monitoring of key perinatal issues to support hospital quality improvement efforts, and that is how the Perinatal Quality Indicator Initiative came about, or PQI for short. PQI reports key perinatal indicators that have been adapted from leading national groups and are revised often to ensure relevance for the state. You can see in the map that 56 hospitals are currently part of PQI. However, there are 111 burden facilities in the state, so we continue to recruit others. For participation, we have tried to make it as easy as possible for our hospitals. We have rolling enrollment, so our hospitals can join us as soon as they are ready. There is no charge for hospital participation, and we are very fortunate to have the support of the Florida Department of Health for this project. Hospitals do not need to submit any data. We actually utilize existing birth certificate and hospital discharge files. And here again, thanks to the partnership with the Florida Department of Health, we can access birth certificate data 15 days after the end of the month. And that allows us to update some of our indicators very promptly. This is a huge advantage here in Florida. We ask few things from our participating hospitals. So first, hospitals need to assign a permanent contact person who needs to comply with training requirements, which is basically 2 30-minute EAT modules where they learn how to read the report and how to identify areas of improvement. They also need to participate in 2 short surveys per year, and they need to promote a quality improvement effort within their facility. With that, they get a very rich report. In the report, there are 9 key perinatal quality indicator sets. You can see them listed here. Indicators are reported over time for the last 5 years of data available and include initiative-wide percentiles for comparison. Also, to help explain the main indicators, there are 30 sub-indicators in the report. Now, imagine the effort that it took to generate these reports in SAS and Excel for more than 50 hospitals. It was a lot. That is how we used to do it until 2019, when we started exploring other options. So the need to improve the timeliness, accessibility, and granularity of the PQI report and the creation of a dashboard came in part due to that increased burden I just mentioned, but most importantly, it was requested by our PQI hospitals in the survey they take every year. Hospitals reported the desire to improve the granularity by examining their indicators stratified by various patients and hospital characteristics such as race, ethnicity, payer source, and NICU level. Hospitals also requested more frequent updates to improve responsiveness to emerging issues. Finally, there is also the desire of the collaborative to increase hospital participation with the potential to include up to 111 burden facilities. And with that, we hope to address the issue that we had, right? The burden of generating reports and having a static report that didn't have any interaction. So there is when we chose Power BI to automatize our initiative. This data visualization tool allows for user interaction with the data improves data visualization of indicators with graphs that are more user-friendly and slicers that are very easy to use. It automates processes to minimize potential errors and facilitates the development and dissemination of new reports and reporting options while maintaining data security. On the right, you can see one of my favorite features in Power BI. Power BI is like a relational database where you can connect up to 70 data sources and establish relationships to create very rich interactive reports. Power BI is the data visualization tool we chose, but there are other data visualization tools available in the market. My intent is not to promote one specific tool, but to give you an example of how we have used it to support quality improvement in our state. So in regards of our PQI dashboard report, I will show you a sample of the report. And I can tell you that hospitals can access their PQI report online through a password-protected account. It has built-in features that allow users the capability to examine a QI indicator dashboard and hospital maternity profiles. So let's look at it. Once the hospitals gain access to the report, we send them a link and they can put it in their favorite browser and access the FPQC Perinatal Indicator System report. So this is the landing page. You can see it here. And I always recommend my users to do a full screen so they can gain a little real estate in the report. So here you can see that we include a hospital profile, a dashboard summary, data quality dashboards, and then 9 key perinatal quality indicators that we had already spoken about. For the hospital profile, if we click on it, hospitals can see the characteristics of the population they serve, how they compare to the Florida average, and any changes over time. So you can see here the years. They can quickly see if there's any changes over time for their population. This particular hospital doesn't have any changes, but some hospitals will start to notice as they go through the years that for some years they may have a higher proportion of unknowns. And this is a very nice feature that allows them to see the quality of their data in a very quick glance for certain data elements. They can also compare only to NICU levels that are comparable to their hospitals. This hospital in particular is a level 3, so they can click on that, and they can also see by race ethnicity. So if they wanted to see how different services or characteristics vary by their population, they can click into the race ethnicity slicer and get that disaggregation. Now, for the hospital profile, we include maternal race, ethnicity, payer source, maternal age, prior live births, fetal presentation, method of delivery, pregnancy BMI, gestational age, birth weight distributions, and multiple gestations. These are very important variables that within research we use to risk adjust. And so we hope that by using the hospital profile, hospitals will be able to identify those high percentages of unknowns and will work in improving the quality of their data. The second feature we have in the report is a PQI summary dashboard. It provides a snapshot of the last 12 months of data available for all perinatal indicators. And here hospitals can quickly assess if the rate for each indicator is among the highest rates, which would be on this section in the red, if they have rates if their rates are among the lowest rates, and that would be, when that black line, which is the hospital rate, is among the green section, or if they are among 50% of hospitals in the middle, and they would be in those 2 shades of purple. And so it's a very easy way to identify areas where you may be having issues, right? So here, this particular hospital has a high percentage of severe maternal morbidity, of hypertension, preeclampsia, of obstetric hemorrhage. And then for neonatal absence syndrome, they are a little lower. And for NTSB cesareans, they are really, really low. So a couple of things to explore here. First, they can compare to only NICU level that is comparable to their hospital to risk adjust a little bit. And that is going to limit to only hospitals with the same NICU level, of course. And they can see, well, now the severe hypertension is not in the red anymore, right? But it's borderline. So truly other level 3 NICUs actually do have rates lower than this hospital. So this hospital may want to look into those issues. And then they can also look by race ethnicity. So if they want to disaggregate and see any changes and maybe identify quality improvement opportunities, they can do so by just clicking at this picture on the right. And you can see that for non-Hispanic flag, most of the flags went up for first indicators. Now, for NTSB cesareans, this hospital has unbelievable rates, and they are actually a problem because you can see here that we have this little flag for data quality issue. Any hospital that has data quality issues for each of those indicators is going to get a little flag that will alert them that rate may not be real. They need to work in the data quality first if they want to have a real rate. So the first thing to do is to observe time trend graph. And if they go here, they can see that for a quarter, they were almost at 0%. So definitely an issue. And here again, you see those little flags. Actually, this hospital had 2 flags. They have issues in 2 places. So the first one, they have a percent unknown or missing in the birth certificate for vertex. That is to identify if the infant was head first, right? So if we are looking at cesareans in this population, having a high percent of unknowns is going to be an issue. And so this rate is not real for this hospital. They need to work on identifying those patients adequately before they can use that indicator. And the other issue they have is on agreement. So agreement comes from the link file, and that is the one data set that is very, very extremely delayed in Florida. And so we have that agreement percentage at 62%. Definitely not something this hospital should be using, and definitely an area of opportunity to improve data quality. So those are the 3 main features that we have added lately. So hospitals can assess data quality, they can look at quick summary dashboard, and they can also look at hospital characteristics. And then these are the graphs that the hospitals usually look at. There are time trends where they can compare how they're doing against other hospitals in the state. So you see 4 colors, it's because it works as percentiles or box plots. Basically, you have 25% of hospitals in each one of those sections. And so very easy to identify if you are among the low-performing hospitals or the high-performing hospitals. Another one of the tasks was to share barriers. For us, it was the time-consuming step that we needed to take for the initial setup. So we needed to meet with our IT department to determine the capability of the tool. Once we decided that the tool was usable for our project, we had to go through the amendments to the data user agreement with the Florida Department of Health and ACA to include permissions to share data online. And then we used a lot of guidance from the FQC advisory committee to make sure that data we were generating was useful for hospitals. And then this was a very important step. We had to assess potential usage needs by hospitals. That was important because based on usage needs, we would determine the capability that we needed to lease for the hospital interactive server. So the license to use Power BI at a premium capacity that allows you to share reports with others outside your organization has a cost, and the license is expensive. So we had to procure those fundings, and we were lucky to have the Department of Health support our project. Finally, we had to create a secure cloud to house linkages to databases and reports, and then we had the opportunity to build a project in Power BI. Just a little tip, if you're curious about Power BI, you can download Power BI desktop for free. It's only when you want to share the report with others that you need to purchase a license. But if you just want to explore the tool, you can do it for free. And then the other difficulty we had was to secure access for hospitals. And we had to create an account for each user because it has to be accessed through a password protected behind the USF firewall to protect the data online. So we had to create one account per user, and then we had to ask our hospital leads to share the legal name, date of birth, email, and cell phone so they could do double authentication. Once that was set up, we had to activate those accounts and then provide access to the report online. And one of the biggest things we had to do was to help them troubleshoot issues when they couldn't access that report. So the lessons learned: one, we had to train our hospital leads on report and dashboard usage. Otherwise, it's just a pretty report out there that nobody uses and looks at. So we have to train our hospital leads on how to consume the report and dashboard. We need to do follow-up with hospital leads and ask for feedback at every stage of development to make sure that we're getting the right product. And then we need to integrate an equity lens into existing dashboards so we can produce actionable insight. So for now, we only have the race ethnicity slicer, but we're working on an equity dashboard for the report. Finally, we need to provide quality improvement support and initiatives to continue the work, because remember, data on its own doesn't do much. It's actionable steps that actually get you change and improve maternal and infant outcomes. So this is a tool to increase awareness. This is a tool to identify issues and windows of opportunity. But at the end, we need hospitals to work on these issues to actually see changes. So that is all I had for you. This is my email, and also I've included FPQC's email. You can contact me or anybody on the FPQC team. We would love to bounce ideas or provide additional detail on our project. And if you made it this far, thank you so much for your attention. I really appreciate you, and I hope to hear from you. I wish you a wonderful day. Thank you.